right? Especially if you come to Texas. Welcome to Texas. It's horrible, okay? So when you see allergic rhinitis, something that's going to be very, very common, kids, adults, young, old, doesn't matter. You're going to see this a lot. Conjunctivitis, not as much, but your allergic rhinitis, absolutely. Your ELOs, same things that we always talked about before. Again, just paying attention to mechanism of action, adverse drug effects. And then whenever you have a question on the exam, look at the stem, which is the thing that ends in the question mark, and say, okay, what is it asking me? What do I need to know? Okay? And it'll be one of those things that are down there at the bottom. So it'll be one of these things. Okay. So when we look at allergic rhinitis, different patients can present in different ways. It depends on, just because they typically have certain symptoms the first time that they have an allergic or allergies doesn't mean that that's going to be the same thing that they have the second time, right? So they can always pick up any of these things. What our meds are treating are going to be your rhinorrhea, sneezing, congestion, or itching. Okay, so your patient will have either one of those, or they can potentially have all of these, okay? Then, whenever you're diagnosing them, of course, I'm not going to ask you about this part, but they're going to have these symptoms for several days, for a long, extended period of time, and that's what's going to make them end up on some of our medications that we have. So, this is what we're looking at, our intermittent or persistent. Intermittent meaning only in certain seasons will you see that this person is having these flare-ups. So sometimes if you have a person that comes in for allergies, especially if they're complaining about a lot of congestion, things like that, you can look at their chart and say, let me see what happened this time around last year. A patient doesn't know, but you can easily pull it up and see, and like, oh, you keep coming around this time, so maybe you're allergic to something that's happening in this season, right? So then you can pre-treat them, prophylactically treat them before that season comes up. And then you're persistent. It doesn't matter what's happening, they have allergies, right? They can have allergies to dust mites, they can have allergies to mold, all of these things that are around no matter what the season is, okay? Some of these people, they're very uncomfortable because they will wake up in the middle of the night, different things like that, which is kind of what we'll talk about with allergies as well, same type of concept. So this is the old way, sorry. This is the old way that we used to classify, but you'll still hear people saying this. And then you have the new way in which we can classify, and it's based off of the frequency of the symptoms and how severe it is. So this is just saying 4 is like the magic number. So if they're not having symptoms more than 4 days a week, you'll say that they're intermittent. And then if they're having more than or greater than or equal to 4 days, then you would be saying that they're persistent. I will tell you how your patient is presenting, okay? This is just giving you the information on where that comes from. I will say, oh, this person has intermittent, moderate to severe, or intermittent mild. I will tell you, okay? And then their mild is just saying nothing is really disturbed throughout their day, right? They can sleep. They're carrying on about their normal lives, but maybe they're just sneezing more. Maybe they're, having the itching, different things like that more. Whereas your moderate to severe, these people, they're getting waking up out of their sleep. They're interrupting their normal daily habits. Okay, so that's just the difference between these two. So this is more so like how they're presenting, how severe is it, and this is saying like how often is that happening. Okay, but again, I will tell you what's going on with your patient. Looking at this is like your pollen chart. So depending on what's going on, you can have your patient go and get tested. So they can do a blood draw. They can also do where they prick your skin with all of the different allergens that we know of, and then see what response comes back on that patient, right? So they'll have like a little raise if they're allergic to whatever that allergen was that they poked their skin with at that time. That is a referral to the allergy clinic. They typically do those. If you have a PEDS patient, you could be the PCM who's ordering it for that patient, and you just send them to the lab and they do a blood draw and they can see what that person is allergic to as well, okay? So depending on what the parents want to do. Our goal, let me help this patient. Let me help them not have the disturbances throughout the entire day. I just want them to be as comfortable as they can be and shorten the duration or prevent it if I can. And then looking at the different things that we can do. So of course the meds are there, but remember you have a pharmacist who doesn't love meds. So your biggest thing that you can try to do is avoid whatever the allergen is, if you know what the allergen allergen is, right? So if it's because of dust, and you ask them very nicely, we don't judge, right? But you say like, hey, just make sure that you're dusting every now and then, make sure there's no dust on the fan. We all forget about dusting a fan, and then you turn the fan on and it has like the big dust buildup on it. That's releasing particles while it's turning, right? So telling them to clean carpet is another big thing that holds a lot of dust mites and just everything, right? So making sure that they're vacuuming frequently and that they're emptying out that vacuum bag. So just the basic things of trying to avoid in cleaning as much as possible are the better things to do. And then, of course, we have our meds. And if those aren't working, then you can end up trying to refer them, and they will go into a lot more detail whenever you send them to an allergist, okay? All right, so these charts. You are going to have to remember these charts, but again, remember, I'm going to tell you how your patient is presenting and focus on just what's in the red box, okay? I don't need you going all down the chart because at that point it's not going to be your problem. So when you're looking at this, make sure that you're saying this person is intermittent, right? And they are mild. That is what you would get from me, okay? They are intermittent and they are mild. Now what do I do to help my patient? How do I treat my patient? So when you're looking at this, this is in an order. You know, typically like I give you a list and sometimes it's not in order. So when you see 1A and 1B, this is saying that this is like a number one choice for you to use, but A is just more preferred based off of like expert opinion and when they did studies than B. But not saying that, you know, like it's bad. It's just we would prefer to try to start them with an oral. So these are all of your acronyms. Everything that has an abbreviation you're going to see over here on your right-hand side of your slide. So with my mild intermittent patient, they have an oral antihistamine that I could be giving, and you see that this says second generation. When we get into the drugs, we are going to see why we like second generation over first generation. They have less side effects than when we're looking at our first gens. Or I could do an inhaled antihistamine. So this one, when I say inhaled, it's a nasal spray that they'll be using. So anytime you're hearing me say inhaled while we're talking about our allergic rhinitis, it's inhaled in the nose. So if you're reading anything and it says inhaled, it's talking about through their nose. And then with a person who has any type of congestion, what we like to do is we like to add on Sudafed. So that's your number 2 option that you have right here, is it saying, hey, I can give an oral antihistamine, which was my number 1 option, one of my number 1 options that I had, and then I can give them pseudoephedrine, which is what's abbreviated as PSE. What I want you to remember about your pseudoephedrine is any time that you hear a person saying that they're congested, doesn't matter which stage they are in, you can always give them pseudoephedrine. Okay, very effective for us to kind of relieve the congestion that that patient is feeling. Okay, even if they're not on anything else, some of our patients will just go and they will just get pseudoephedrine. All right, so that's all I need you to know from this one. When we're looking at intermittent still, but now moderate to severe. So I still have my number 1 looking the same, right? My oral antihistamine with my inhaled antihistamine, either or, right? One or the other. Then I have my inhaled corticosteroids. This is the first time where you're seeing us using the inhaled corticosteroid. I'm using this now because my patient is more like moderate to severe, right? Remember, our steroids are always going to come with side effects. The more I have to use it, the more likely I am to experience those side effects, but they're very, very, very effective. When we talk about asthma, different conditions, your steroids are very effective in controlling the disease and making it more tolerable for your patient, okay? So that's where you'll see your inhaled corticosteroid. Now this looks confusing because of the way that they write this chart, but if you think about this, just remember an inhaled corticosteroid with an antihistamine, okay? So inhaled corticosteroid, inhaled antihistamine. These are essentially saying the same thing. The difference between these is that this is one product, a combo product, because we know that a lot of people end up using these 2 things together. So this just has them combined. Whereas this one is saying, let's say I started my patient out with an inhaled antihistamine, and then I added on an inhaled corticosteroid, and I told them to take it at the same time to see if it's going to be effective before I ordered them the combo product. or if the combo product falls off of the formulary, you know how we get creative. We can make it ourselves, right? So now I can give them that inhaled corticosteroid and the inhaled antihistamine. So this, all you need to remember is that it is inhaled antihistamine and an inhaled corticosteroid, right? You'll see them together regardless because I give you the brand and I give you the generic, okay? So that's what this is. And then now you see what's kind of fallen to the wayside is your oral, right? Now I'm trying to get to the source. They have allergies. They have allergic rhinitis in their nose. So now I'm trying to get to the source as this becomes more persistent. I can give them a nasal versus if it's mild, I can just give them something that's systemically going to work. I'm not targeting that area as bad. It's going to help, but it's not super severe like how we get here. Okay, now I'm into my persistent. Okay, so this is that person who it doesn't matter what's going on, they're always having allergies, right? But they're on a milder side. So when I look at my persistent person, because this is happening to them so much, I need my effective medication. I need that thing that I know that's going to work. So now you see that we have our inhaled corticosteroid that's being the first thing that's used. So this is your number one now because I am persistent. This is happening to me all the time. Give me the best thing that you have to help. Okay? Then you see where I move on to my second line, which is my oral antihistamine, or I can do my intranasal antihistamine. So steroid is first, antihistamine is second, either route, oral or inhaled. And then again, if they have congestion, give them what? Sudafed. Anytime in any of these algorithms, Sudafed. Okay, if you see congestion. So this is there, but it's not. If you see congestion, your brain should automatically go to Sudafed. Pants, anywhere, Sudafed. Okay? And then now for your persistent, moderate to severe. So these are your patients who, again, not only are they suffering with these allergies year-round, but they are getting, their daily activities are disturbed at this point, right? So moderate to severe. So because I am persistent, so what we've noticed with our persistent is I like inhaled options. And I like my steroid to be on board, right? So now I have inhaled antihistamine with my steroid. Remember I told you these two are essentially the same thing, right? So now this is the combo of you giving them both of those things together. So an inhaled antihistamine and inhaled steroid. And then when you, as you go down the line, you see I could use my steroid by itself or I could use my antihistamine by itself intranasally. But all of these are like your intranasal options that are best for your patient. Okay? They are severe. We're trying to treat them. These are the ones that I want you to focus on. When you're getting down here, we're not doing that. Okay? Real life situations, you can say, hey, what have you used anything in the past? They can tell you what worked, and you can start them on that, even if it's not here. Test-wise, just stay in this order, okay? Yes?
Are these all additive, or are we taking it away and starting the intranasal, and then taking that away if it doesn't work and doing something else?
So this we would take away and then put them on something else. It does get to a point sometimes where we do start to stack them and we add. So like my little daughter, she's on 4 different things because 1 didn't work, 2 didn't work, 3, now we're at 4. So like you could end up that way. Sometimes when we switch from one to the other, sometimes you'll get a better response. So it just depends on your patient. But always like if you can give them something that's nice and clean with not so many drugs, they're gonna take it better. Okay, so for our exam, it's one or the other. We would be moving from one that didn't work to the next thing, okay? All right, so this is looking at our drugs. When we're talking about the meds, so these are all of the things that are following are gonna be what we're using in those algorithms, but now we're focusing on our mechanisms, all of those things while we're going through this. So when you talk about antihistamines, there's lots of antihistamines, very popular medications that are used. Your mechanism, and we kind of talked about some of these a little bit, but when you're looking at your mechanism, H1 antagonists, they're just trying to stop that cascade that happens once the histamine is released. So it's trying to say, hey, I want to try to get there first so that the histamine can't bind and then cause the cascade of all of these different things, the mast cells, everything coming to that location to respond, okay? May have some anti-inflammatory activity. This is we're not going that deep. Just understand that it could help decrease some of the inflammation that happens. So you have your first generation and your second generation. This is a big deal when we're talking about our antihistamines because some of them we use in different settings more often than others. So when you look at your first generation antihistamine, this is going to be more non-selective. We have some anticholinergic properties that are also happening. So when you think about something that's non-selective, it's just out there, right? It's binding to whatever it can bind to and it's producing some action. So when I think about that, do I think about increased side effects or decreased side effects? Increased side effects, right? Because it's not targeting anything, right? It's just out there and just binding to whatever it can. So most of the time, our first gens have a little bit more side effects than our second gen. Our second gen, these are more selective and specifically more selective outside of our CNS. So a lot of the side effects, a big one with our first gen is going to be drowsiness. It's like sedation, which is kind of why we use them. Our second gen, you don't see that as much. The risk of having that happen is a lot lower. So if you think about somebody who has allergies, right, this is all day that they're experiencing this thing. So if I give them something that's going to make them drowsy, a first generation, am I helping them throughout their day now? Because now they're groggy, they're sedated, they can't function. That's what we were trying to help them do. So most of the time, that's why we would pick our second gen, and that's why you see second gen on the algorithm, right? Because my person has to go out and be productive, okay? Your clinical use, a lot of times patients, again, are put on these meds and sometimes they're on them year-round, sometimes they're on them seasonally, okay? So just understand that the use or the duration of use depends on your patient and what's going on with your patient, okay? So you see that they can help with several different allergies. Sometimes if my kids have a cold and their nose is running a lot, I can also use the antihistamine because I'm trying to target the runny nose, even though it's not allergies, but it can kind of help dry some of those things up because I have anticholinergic properties, right? So that's why I can use some of these meds for different disease states that may present and cause those symptoms that we were saying we could target with our antihistamines, okay? Dosing. When you look at your first generation, kind of inconvenient, okay? Several doses that they have to have throughout the day. But if you look at your second gen, some of them they can take daily or twice a day. So a lot better with what you're seeing as far as like the frequency of the dosing. So more adherent when we're having our second gen, and we have less side effects. So if we had to vote for somebody right now, second gen is like winning, right? Because it's a cleaner medication, okay? And then you have your intranasal. When we're talking about our allergic rhinitis, right, in my nose, when I give something intranasally, it's going to be more effective because it's going to the site that I need it to go to versus me giving something oral that's just going all over the body, right? So this is where you see that this is more effective in helping with those symptoms and also helping with some of the congestion that a patient may have when we're versus giving them an oral antihistamine that's just going to go around their entire body, okay? So if I give them a nasal one, it's going in their nose, I can help with a lot of things because I potentially have some anti-inflammatory activity. That's why you're seeing the improvement in the congestion, okay? Because I'm helping decrease the congestion that they have so now they can breathe better. Okay, adverse effects, kind of touched on these a little bit. So you see they're broken up. Your first gen versus your second gen. Your first gen has all of the problems. Your second gen is like, hey, I might give you a headache, okay? When you look at your first gen, biggest thing that you're going to see is going to be the drowsiness, which is also why some of the times we use these meds. If people would like to go to sleep at night, Benadryl, right, is one of our first gen antihistamines, and we use that to help them go to sleep, okay? So we're using the medication based off of the side effect, right? Remember, sometimes we have our drugs and we'll use them because of the side effect that we're getting. This is one of those ones. Anticholinergic effects, just make sure that the more somebody uses it and the higher the dose that they're using it, the more likely they are to see some of those anticholinergic effects. So when we talk about that, just drying things up and remembering your patient who has any of that glaucoma, any of those other types of issues where we're worried about the amount of anticholinergic activity, just be very careful in those patients. Hypotension, didn't mention that, but it was on the mechanism of action, how it has some of that alpha activity, so that's why you can see the hypotension occur. And depending on the child, okay? Not every child, but depending on the child, some of them have what's called paradoxical excitement. So you hear about people giving their kids Benadryl at night for them to go to sleep. Sometimes that's not what happens. It makes them go into party mode, okay? I have one, I'm scared to try Benadryl again because I don't remember which kid it was in. But when I give it to them, one, and I don't remember which one, but they're like, let's go. And we're like, okay, that's not what happened. I'm giving it to you at bedtime because we're about to calm down and it usually causes jaundice. You can see the opposite in children, okay? So just be aware of that. And then our intranasal formulations. Remember when we put anything up our nose, sometimes even in our eyes, sometimes you can taste it, right? And so in this situation, some of these meds, they have a bitter taste to them. So whenever they, when they put the tip of the apparatus in their nose, when they breathe in, if someone like sniffs in really, really hard, they're going to get a lot of it into their mouth. So I tell patients, just take a normal inhalation because the more you, and the harder you breathe in, the more of it goes into their mouth, and then they start to not like it, especially if it's a child, okay? So just be mindful of that. And then your interactions, if somebody is doing anything, especially with our, this is more so with our first gen, if they have anything that could cause CNS depression. So any of our other meds that cause CNS depression, or if they're drinking, they're drunk, this can kind of compound that sedative effect that we may see happening in our patients, okay? Because our drug is already doing that. Okay, this is a chart that's telling you what we just talked about with our first gen versus our second gen. So these are all of our first gen antihistamines that we have. The drug is listed here. This is the brand name. Of course, you just need to know your generic name. And then this is just telling you, hey, how likely am I to experience some of those side effects that we talked about? And the biggest ones that we talked about was the sedation and that anticholinergic effect that the patient could experience. Okay, so when we're looking here, oh, these are pretty good, right? My phentermines, these aren't causing so much of that sedation, but I do have a middle ground when I'm looking at my anticholinergic effect. And I see that my chlorpheniramine, I like to use this in pregnancy, and it's category B. When I look at my diphenhydramine, this is what we know as Benadryl. Remember, anything that you see that has PM in it, all of that has Benadryl in it. So if you look at the ingredients on the back, you'll see diphenhydramine. That's why they're calling it PM. So NyQuil, which it was Dayquil, the NyQuil just has Benadryl in it. Any of these things that you'll see, they'll take Benadryl and they add it to it to make you drowsy or sedated. So that's why we have the PM after those drug names. You see that we can use it over the counter as a sleep aid. Also safe in our kids who are over 6. You can also weight-based dose this in children who are under 6 years old. So again, this is just what's on the label, especially if they're getting it over the counter without you involved in that. Your promethazine, this is just high all the way across the board. This is what people were mixing with the codeine, so the promethazine and codeine, and this is what was causing a lot of respiratory issues with the patients, because not only were they messing with their CNS with the promethazine, but then you have codeine that can also cause those same issues, right? So now I have this additive effect of these two medications being used together. So we're looking at this a lot of the times. We'll see this used in the inpatient setting. We push this for like patients who are having nausea and vomiting. They're after receiving some of their meds for anesthesia, we can push this to help them kind of come back down from that nauseating feeling that they may have. Hydroxyzine, meclizine, again, these are very, very common ones that you can use. This is inpatient and outpatient. Your meclizine, you use that more so for like vertigo, that you can have some of our patients experience, and your hydroxyzine, more so for like itching, hives, things that patients can have. If they have an allergic reaction to something in an inpatient setting, sometimes you'll also see us use this. Between this and Benadryl, we use either one. And then your cyproheptadine. Have we seen that one before? Right? Yes. Serotonin syndrome. So just remember that. But this is where it actually falls. It's an antihistamine. Okay? But as long as you know, hey, I'm using this for that serotonin syndrome, you're good. Second gen, we're at the fresh air, right? Looks completely different. Everything is well balanced, it's well managed. So my second gen is like my 2.0. I have less side effects. My biggest thing that I was worried about with my second gen was that headache. That's the most common thing that I see, okay? Looking over here, you see that you have your different drug classes as far as pregnancy. So loratadine, you can see this used. You see also that you can see your cetirizine. Also, I know people are going to ask, let me go back. I don't care that you know which class this is in. If it helps you, fine, but I don't need you to know the subclass of the first generation. Just know that they're in first generation, and the side effect profile is trash, okay? That's what you need to know, right? So, like, don't look and say, like, oh, diphenhydramine is a methylamine. I don't care about that. I'm not asking you that. I just want you to know that it falls into this class, first generation class, okay? Not subclasses. Same thing for this one. Just know that they're falling into the second gen. We have less side effects, right? I'm not as worried. And what are my medications that fall in the second gen? Then you see here that we have a different route. I have my intranasal. So these are the ones that we were saying that we could use in conjunction with that inhaled corticosteroid to kind of get an improvement, right? So I have my azestylin and my olopatadine, and we'll talk about these, and they're going to also come up again when we talk about conjunctivitis. So some of these drugs that we're looking at in the first half, you're going to see for the nose, you're going to see some of these again for the eye, but different formulation, right? Instead of being an intranasal spray, it's going to be an eye drop, okay? So you're going to see these. Don't get confused, because that's the biggest thing that we have. Told you all this already, less likely for the second gen to interfere with their daily activities. So that's why we like our second gen better. 2.0s of the first gen, okay? Anything else that I want you to look at here? We'll kind of talk about these a little bit more whenever we get there, but these age cutoffs on some of these, I do need you to remember them. Because you're going to have those patients that could be that age, and you need to know, like, can I give this, or would I be doing something like this off-label? So, for instance, this says 6 years old, but my daughter she just turned 4, and we have her on this because nothing else was working, right? So, doesn't mean that it's not safe. It means that we don't have enough data to support that. So you can just send them to the allergist, because my PCM didn't want to do it. Send them to the allergist. I said, hey, can we try this? And they're like, sure, let's see. And it works, okay? So you would just, if it's something that's outside of this range and you can't find a weight-based dose for it, then you just refer them to the specialist, and they will likely say, okay, yes, we can try it, or no, we're not going to do it, okay? All right, your leukotriene antagonists. These medications are very good medications. We like them, especially when we're looking at our rhinitis and just allergies in general, because I can use them in little tiny kids, right? So you see here, these granules and this chewable, that helps me with my kiddos because I can drop all the way down to 6 months, okay? The granules, I can mix it in milk, I can mix it in juice to just try to get it dissolved so that the child can take it in applesauce, however they want to do it. And then the chewable tab, they'll just chew it. It's like a grape flavored thing, and they chew it and it's fine. It's not huge, it's like a small regular little tablet. And then you have your other, these are just different doses. Of course, if they're younger, then you don't need to start them off with 5, start them off with 4, because this med does come with side effects that we're going to talk about. And then this is where most of your adults are going to be, at that 10 milligram. So, looking at my mechanism, it's in the name, inhibits your sustainable leukotriene, right? So leukotriene antagonist, I am blocking this, all right? So if you remember the name, you can kind of remember your mechanism. What that does is that decreases some of the inflammation that we have, because that leukotriene is a part of our cascade that we're going to look at on the next slide that tells you how inflammation occurs. So if I can block this, then I can decrease the amount of inflammation that my patient will be experiencing intranasally, right? So you see, comparable to my antihistamines, but nothing is better than my steroid. Remember, my steroid was that thing whenever stuff got real serious, we were introducing that intranasal steroid. So this is telling you all the things that we've seen so far, they're okay, but they're not as good as my intranasal steroid, okay? Well tolerated, headache again being that thing, kind of like our second gen. Headache is the most prevalent thing that you'll see. But this one does come with a black box warning specifically for your Montelukast. So there's another one called Zapralukast, but we don't use it typically whenever we're looking at our allergies is not prescribed as commonly. So that's why that one is not on the slide, but there is another drug that goes into this class that you'll see here. But when we're looking at our black box warning, Montelukast disturbs their mood, that psychiatric disturbance that they have. So they'll hear voices, they'll see things that aren't there. It can increase their desire to commit suicide if they already had something like that kind of on their mind. So just think about all of these different things. Just think of it as like psychiatric disturbances, okay, is the black box warning. So Montelukast messes with their mood, okay, messes with their mind. You see that we have some CYP inhibition happening, specifically if we were looking at our Zarfolukast, that's the other leukotriene inhibitor that we have, okay? So Montelukast, you don't have that same interaction, but you also don't have that bad black box warning whenever you're looking at your Zarfolukast versus your Montelukast, okay? Oh, other thing with this, bedtime. They take this whenever they're going to bed, okay? So that's an important thing. I usually don't tell y'all to remember doses. Don't need you to remember the doses, remember the age and that they're taking this at bedtime. We have lots of formulations. I can help my 6-month-old kiddos with this one, and they're doing this at bedtime, okay? So this is just that cascade that I was talking to you about. So stimulus would be whatever that allergen is that they came into contact with, and then it's going to cause all of these different things. Y'all have probably seen this more than you wanted to see. Have y'all seen this chart before? And anything else? No? Not yet? Okay. So I'll go over a little bit more. So then you have your different drugs can attack different areas in this cascade to prevent the downstream effect of having that inflammation occur, or bronchospasms, congestion, stuff that we're going to talk about when we talk about asthma as well. So phospholipids, your arachidonic acid, and then you're seeing how we go down here. We have our steroids who are working higher up in the chain, so that's why we see that they're more effective most of the time, because they're cutting off stuff at the very beginning. They're not letting it go on. They're saying, hey, we're cutting this off right now, right? So that's why we see that effectiveness being a lot better when we're talking about our steroids. Lots of side effects will come along that we'll talk about. So what we just talked about was your leukotriene inhibitor, right? So we were trying to say, if I can stop this, look at what I'm preventing. I have some decreasing inflammation, and now I can help prevent a bronchospasm, any congestion. If there's like a lot of mucus that's causing that congestion, all of that can be prevented. So think about your Montelukast or your singular, because this is going to come up again when we talk about asthma as well, because I can help decrease a bronchospasm from occurring, which is my big issue in my asthmatic patients, okay? All right, your decongestants that we have. So when we look at these, essentially what we're trying to say is somebody is stopped up, right? They can't breathe out of their nose. They come in, doc, I've been like this for X amount of time, and I want to feel better. Help me. These are your different meds that you have. Your oxymetazoline, which is your Afrin, your pseudoephedrine, Sudafed, and then your phenylephrine, which is your Sudafed. Be very careful whenever you're suggesting or when you're ordering Sudafed, right? Brand name use is great because it's shorter sometimes, but this is confusing to a patient if you just said go and get Sudafed, because Sudafed is a huge brand and they have several different ways in which they can give you Sudafed. Your most effective Sudafed, brand Sudafed, is your pseudoephedrine. So pseudoephedrine is the most effective form, whereas your phenylephrine is more selective than our pseudoephedrine, but it's not as strong. A lot of your patients will come back and complain that they're still feeling congested. They don't have to buy this one and go behind the counter at the pharmacy to get it. This one, because you can use it to make meth, the patient has to go to the pharmacy and show their ID. They don't need to have a prescription. They need to have a state-issued ID, okay? What happens is the pharmacy will then say, oh, you wanted which one? So you can tell them, go get Sudafed, but it needs to be the one where you need your ID behind the counter. If they're getting it over the counter, it's the weak stuff. It's not the good stuff, right? Remember that, because I can make meth with the good stuff, not with the stuff that's over the counter, right? That's why we have it behind the counter, okay? So whenever I look at that, I take their ID, I scan it, and then it logs how much they're getting. There's restrictions on how many they can get per day and per month, and it tracks it, so that we're trying to curtail how much they're just being able to buy to actually make meth, Okay, so it makes it more difficult for them to do it. So paying attention to that is a big difference. One is a little bit better, stronger. This one, not so much. Might get pulled off of the market. We'll see what happens because lots of people complain about it. All right, so when we're looking at our mechanism of action, just looking at this and saying, hey, alpha agonist, right? So we talked about that last semester, all of those same things that we would be expecting to see happening whenever we have alpha-1 agonism is occurring. So blood pressure going up, and when you see all of this mechanism, think about this as a lot of things as to why you would also potentially avoid using this drug class in some people, right? So if I have high blood pressure already, is this a great option for me to use for a long period of time? Probably not, right? And they're oral, right? So they're not targeted at just one, they're not targeting just my nose, they're going throughout my entire body. So I have that alpha agonism happening now everywhere, okay? So that's where you see increasing my blood pressure. If I have cardiovascular issues, those are the two big things that you'll see, which is also drug companies are playing up on that as well, and they're making drugs that say, oh, this one is safe in hypertension. This one is safe if you have high blood pressure. But they are real things that we need to watch out for. So you see all of the different things that can happen whenever we're looking at that. No effect on anything else. So no effect on my itching, my sneezing. None of that is being affected. My runny nose, I'm literally just helping with the congestion that is happening, okay? So it is a decongestant, nothing else. That's it, right? Your pseudoephedrine, you see that again, we talked about how effective the pseudoephedrine was. That's also partly due to the fact of the PK parameters and the fact that it's going into the CNS. So you'll hear some people also complain. We'll talk about some of the side effects of that, but like they'll say like, oh, I feel very like amped up and hyped up if they take this at night. So we just tell them, okay, don't take it around bedtime, right? And some of these we have in a 24-hour dose or a 12-hour where they have to take it every 12 hours. And some of them we have where they take it every 4 to 6 hours, depending on which form they get of the pseudoephedrine. Your dosing. So looking at this, if you know that somebody is going to come in contact with an allergen, they should be prepared. This is if you have the option to do this, right? I know I'm allergic to cats. I'm going to go buy a cat, or to my friend's house who has a cat. I know what time I'm going over there. Let me take this because this is the one symptom that I have. I know I'm going to get congested, right? Or I'm allergic to a dog, but I have a dog. Same thing. You know that over time what can happen is you could potentially not have that allergy anymore because you're desensitizing yourself. But initially it might be horrible, okay? Bless you. So when you're looking at this, understand what you are targeting. How is your patient presenting? What symptom are you trying to cover, okay? Because if I'm talking about congestion, I need a decongestion on board, okay? Any congestion requires a decongestant, okay? So if your patient shows up and they're congested, you need to give them a, what were my three that I had? Y'all tired from the exam? I am too. Okay. I'm so mad that I messed up that question, but anyway. So we have our phenylephrine, we had our pseudoephedrine, and we had our oxymetazoline or our Afrin, okay? Remember, any three of these things can be purchased over the counter. We do have within our DOD system where you can order these. We do have them and they don't have to pay for them, okay? If you order the Sudafed, this isn't something that your patient should be on for a very long time, by the way, but if you order your pseudoephedrine, you don't have the same limits that they would have if they needed to go and show their ID, okay? So if they needed to go over it, don't use that in a bad way either, y'all, because that's your license. But they don't have those restrictions that we have if they were to just go and buy it over the counter because they're trusting that the provider is looking at how much somebody is using. If they're always congested, then maybe there's something else going on, right? Maybe we need to get them on some other maintenance meds. This is just to help them like acutely try to get through the congestion that they're having. Also, you see your topical application less than 10 days. What it means by topical application when you see that is nasal. So if I'm using something intranasally, that's going on topically, okay? It says 10 days. We stick between 3 and 5. On the exam, if I ask you, I'm expecting for you to know 3 to 5. So if you have a patient who is using Afrin, because that's the only one that we have that is the nasal formulation, the other two are usually going to be given in the tablet. But if you have someone who's using it all the time, what will happen is if they use it over that 3 to 5 days, and this med works fantastic, it's amazing. But when you use it over 3 to 5 days, and then you try to stop, your body, you automatically get congested again. So that's that rebound congestion that they have, okay? If you give this to a patient, make sure that you counsel them, make sure that you write it out on the instructions, no more than 3 to 5 days, because then they're going to be miserable, because sometimes it takes up to a week for them to actually stop using the medication and go through withdrawal. While they're going through withdrawal, they're going to be super congested. But you can give them one of the oral, the pseudoephedrine, to kind of help them through that congestion period, okay? And then your drug interactions, our MAOI inhibitors, make sure that you have at least a 2-week washout because of that hypertensive crisis that we talked about last semester. It's the same exact thing that we kind of saw already before. Looking at my adverse effects, remember I told you about the mechanism? These are all the same things that you're seeing within that adverse effect. So CNS stimulation, if that blood pressure gets high enough, or if we have that heart rate get up high enough, you see that we have a stroke that could potentially be involved. This is like worst case scenario, seeing a stroke. Remember we had that anticholinergic effects as well still, so you have your urinary retention. If you have a patient who has diabetes, doesn't necessarily mean that you can't give it to them. Just make sure that you're monitoring it, because it can alter your treatment that you are giving them for their diabetes. If they're using it for a short term, just understand that you may need to supplement at that time if it is required. But it's not an absolute contraindication where you cannot use it. That rebound congestion we already talked about, which is why we're limiting it. We said already in the beginning, watch out for your patients who have glaucoma, because again, that can cause that increased IOP. And then nasal irritation. So when we're telling our patients who are going to use the intranasal form of any of these meds that we talk about today, they need to make sure that they're pointing it outward. When people point it in, they can either perforate, or what you'll have a lot of is nosebleeds. And it's because they're starting to dry out those nasal passages, and then they start to have several nosebleeds. You can then give them saline to help moisturize their nose. But again, now you're giving something else. Saline is okay though. Some people use it every day just to flush out their nose from all the gunk that they had throughout the day. And it's a natural thing. It's just water with salt essentially in it. So when you're looking at this, just make sure that you understand that there are some side effects that people don't think about, or things that could happen if they're just not administering it properly. So I always ask my patients when they come back and they're like, oh, I don't like this stuff, it's making my nose bleed so much. How are you putting it in? Well, I just put it up in my nose like this. Like, are you doing this, or are you doing this? And you could just show them with their hands, like point outward and inhale gently, okay? That's all they need to do. All right, your phenylephrine. This is the one that we have. It's out there, not fantastic, may or may not stay on the market. We'll see. Same type of mechanism that we saw before with our pseudoephedrine. And then looking at your clinical use. We talked about this, and where you will see this used effectively is in the inpatient side when you have somebody who has shock. So we talked about that last semester. So your shock, because they're going to be hypotensive, this will help bring that pressure back up. And then your eye procedures to try to help with the dilation there. And then your relief when we're talking about red eyes, right? So we think about Visine as being something that's kind of similar to this. We'll talk about that on the next slide. Kind of similar to this, but this is something that I don't see purchased a lot. And we don't even have this on the inpatient or like on the pharmacy side within our DOD formulary. Again, it's just not super effective. Most of the time, this is our best clinical use that we have for phenylephrine is going to be the IV formulation that we're doing in an inpatient setting. Monitoring their blood pressure, again, because of our alpha agonistic effects. Adverse effects, bless you. Remember I told you this, again, last semester type of slide, but You can have the extravasation whenever you're using it for a shock, which is not the indication that we're using it for here. You can have that headache that could occur because of the fact that I have increased their blood pressure. So the same thing, all of this is tied back to that mechanism. And then if I'm using it over the 3 to 5 days, because it is a congestant and it is a topical application, I can still have that same rebound occur with this one. Interactions, of course, if I have an agonist, a blocker, atropine because of it having additive side effects to what I would already experience from the phenylephrine itself. Okay, so that's just additive side effects. Okay, your oxymetazoline. This one is, again, your Afrin. You can get this over the counter. There's different forms of Visine that we have that can get the red out. Remember, Visine gets the red out. So this one, you see that now your mechanism has changed up a little bit. You have alpha 1 and 2 versus our other ones we were specifically looking at alpha 1. And then you see that we have 2 different formulations that we can give. You have your nasal and you have your eye drops. And so essentially what that's doing is helping with the congestion, helping with the redness, kind of clearing up their eyes. Okay, so it just helps with the appearance. It's just a decongestant. It's not helping if their eyes are itchy. This is not going to help with that. Okay, this is just helping with the appearance of how that patient is showing up. But if their eyes are itching, they have the conjunctivitis or anything like that, that's different. You're going to need a different med on board. Looking at our, don't worry about this, again, because these are both topical formulations. Make sure that we're not using it more than that 3 to 5 days, okay? So I'll stay consistent. It'll still say 3 to 5 days if you see any of that. Same thing happens with the eyes that happens with the nose with the rebound congestion. So now if I am using that Visine and I keep using it all the time, then what happens when I stop using it is that I will start to experience the redness because now my body is missing the drug. So I have that rebound of the redness and of the eye. So that's all of these things, the stinging and the burning, just by way of the administration of the drug. We'll finish this section before I break. Our pseudoephedrine. So again, this one was our more effective one. This was the one that was going and crossing that CNS, doing the CNS stimulation as well. Now I have alpha and I have beta activity. I also have some indirect action whenever I'm looking at my norepi being displaced, okay? So that's why you can hear some of your patients say that this could be activating for them and why we tell them not to take it around bedtime. Good, very good for our congestion. This one is the one that's behind the counter because we can use it for meth. If you have a drug test, which is why for active duty I like to have it prescribed versus telling them to go and get it over the counter because then they have a medical record that a provider told them to take it because you can have a false positive detection of amphetamine if we did a UA, okay? So that's why I like to be like, oh, hello doc, can I get some of that good old pseudoephedrine please? Because you drug test me, it's right here, it's on my profile, I have it, okay? These are just some of the limits that you will see. So the daily sales, remember I told you we limit how much they can get every day, and we also limit how much they can get in a month. So 3.5, or yeah, more 3.5, 3.6 a day, 9 in a month. And sometimes you'll see people, they're like, oh, I'm over my limit, and they'll ask the person behind me, like, hey, can you buy this for me? I'm like, you can't do that in front of me. It's a limit for a reason. So like, go in the parking lot and do whatever. Do your drug deal in the parking lot, come back. Right? So like, make sure that you're understanding that there's 2 ways. They don't need you, but if they don't have you involved and they're having a lot of congestion, they're going to hit this issue in the pharmacy, okay? So also ask them why they're having to use it so much because that shouldn't be happening either. And then a quick note, because we had that alpha agonism that was happening and that stimulation that was occurring, these are all of your different disease states that we should be mindful of. It doesn't necessarily mean that they can't take it, okay? But we do need to make sure that we're being mindful of these things and that you are monitoring the patients because some people are very sensitive to medication, okay? If you have them stable and they're taking something and they're good and then you say, here's the pseudoephedrine that you're using for 2 or 3 days, maybe a week, that can throw off their entire regimen, right? So your CHD, hypertension, thyroid, diabetes, glaucoma, BPH, right? Because we're retaining, we're having those anticholinergic effects, so that's why we're worried about some of these things as well. And then your phenylephrine, that's why the debate about if this is going to stay on the market or not. This does have less of those cardiovascular side effects in our patients. Just understand that it may not be as effective, okay? So can you use it? Theoretically, yes. Do you typically use it for that? No, you would monitor your patient. But if your patient was like a recent MI, some type of cardiovascular disease, just stay away from it, and you could try to give them phenylephrine, or you could try to give them the intranasal steroid or something else besides trying to do the decongestants to see if that steroid or even like a breathing strip, anything besides, I don't love phenylephrine. All right, when you come back, we'll finish these. Let's go ahead and take our break.
Back in. Yeah. Almost. I appreciate it if you keep up with that until no test.
Oh, this is important.
They never get off. But we say it's working more firm. Nobody knows. So yes. On paper.
Not special.
Now I'm part of like.
Sounds very chill.
Yeah.
Other than studying.
Nothing special about it.
I like seeing that. 7 organisms on the lot for us. Do you remember that? Like, oh shit. I could have sworn. Bacteria, stuff.
That's a waste of time. Yeah, that's all. That's I would just cancel Yeah, I was like, well, they haven't tested it. I knew that. So like, yeah, they didn't. Like, I know they were saying like they didn't happen on Friday or Monday. So they had like a big ass break. So they had half and lab, AT&T. So they started like next week.
All she has is the lab, you know? Because I checked not even the lab. Like, the lab is there. No, she said she will upload the answers for the lab. I didn't see it.
See this, it's just like damn.
I tell myself like
You're getting so fun, so like, if you
studying and I like questions. But it's the same story like over and over again.
I bought the second one. Dude, that shit was like I knew it was like a pocket. I didn't realize how small it was. I was like, oh, it's like a big book. Big ass Amazon box. It's pretty simple to read though. I mean, I was looking through it like, it's extremely simple. How should and it's cheaper than we started with. In fact, we have the first time starting next week and we start in 2 months. So it's like a week or 2 where like we only have like 4
No, people say we should take a 30 minutes.
ID, GI, Neuro, Ortho, Break, per TV, PHARM.
Do you go yesterday?
There was all like, you know, by the time we get the farm, like we finish farm up, we only have a few more. We have the last GI, third cardio, MPH, last quarter, last neuro, and then last training. And then we done. Get the GTFO. Yeah, like, when I was trying to look at it, it kept going like up and down. First time I did my study, I remember that.
we put our name.
Yes.
This is a boss. Open up
She just changed the grades.
that quick? Damn. You said you got 98, but I think you got it right. He's like, I'm a smart
I
man.
got that one right.
I think you got it right.
The order.
If
If
it's-
we're talking about order, if we're talking about the
If it's
specific,
I could also be wrong. That's not.
it didn't make sense.
Yeah. Oh. I thought that was
He said, because
Which question was it? Do you know which question?
It's not the one that I thought that was wrong, because I didn't get it changed. I missed the math one like an idiot, because I thought I had to round something. I thought it was, like, I've done medical math for years. I thought she said at some point we had a round for the carbs, so I rounded like an idiot. But the one I came up with wrong was the one about the thyroid stuff. That's the one I care about. Steroid. Because that's what it says.
I put iodine.
Well, what's the last one? It said it blocked. It said blocked peripheral T4 T3 and vascular stuff, right? And what's the?
It does the vascular.
It is vascular for the thyroid gland, but it wouldn't say specific glands. I put steroid because it says right here, corticosteroids reduces the conversion and promotes vascular.
I choose something else.
Stability.
I just did the order. I was like, okay,
That's
we did
not
that
what
one.
it's saying. It was saying that it's constricting, so it's decreasing.
Which is systemic.
Not systemically. It was making it smaller.
That's for the thyroid gland.
It said something about vascularity. That's
When you're going through a thyroid crisis, what's the issue more at hand? Your systemic or your thyroid gland? Because
Well,
you're being attacked systemically.
But
Yeah,
we'll
I
make the thyroid
understand that,
smaller
but-
for thyroidectomy.
But that's what. But that was what. That's,
I got it.
Let's go argue this one.
Yeah.
No, this one. Oh, it was the old. It was the
the
levothyroxine.
old person. Yeah, I remember that one. Like,
25 milligrams.
it kept coming up on the list.
And I read. I feel like it was in my mind, but I didn't know which one it was. Oh yeah, What were you saying? What do I put? Is there another one? Am I doing the wrong form?
No, that's right. Like a white box. I don't know what, like, I just know the one, after the time I had.
For sure, write me down.
No, I think it's the
Alright, you ready to get that started? No? Alright. So this is just a summary chart of what we talked about, right? It's all of your decongestants all listed here together. So your phenylephrine, your pseudoephedrine. You're gonna see this abbreviation a lot as we continue to go through things with the for congestion. So PSE is how we abbreviate the pseudoephedrine. Your oxymetazoline, which is your Afrin, and then your phenylephrine nasal or topical, okay, that you have. On here we see less effective. On here it says avoid prolonged use. I will tell you something about this, which is one of the conversations that I was having. We try to avoid the prolonged use. Is this something that we typically do like in real life? No. Sometimes we'll have people who have like Claritin D or Allegra D, and they take that consistently because the way that they present, they always have congestion. Could you potentially change them to something else? Yes, but we also have some people who, this is what they prefer. They don't want to spray anything up their nose, so we can put them on this. Testing purposes, me, pants, anywhere else, you don't want to leave anybody on it. It's kind of like how we talked about proton pump inhibitors, right? It says don't leave people on them for a long period of time. What do? We leave people on them for a very long period of time, okay? So textbook answer is what you will be tested on in here and on the pants. They're going to ask you your textbook answer. And then again, just knowing your different formulations, your oral versus your topical. This is what we were just talking about before. So any of your allergy meds that you have that are available in the oral formulation with that antihistamine, what you're seeing, this is your antihistamine portion. what you're seeing is that I added pseudoephedrine to it, so now their name just ends in a D. Okay, that D is for the decongested portion of it, which is going to be your pseudoephedrine. Okay, so anything that you see with D on the end has the decongestant in it, and it's typically with pseudoephedrine in it. Different ways that you can administer these. Some of them are once daily, which are the ones that people tend to lean towards. So again, something that's also in the name. So the Allegra-D 12-hour versus the 24-hour, this one costs a little bit more if they have to pay for it, but this they're taking twice a day, this one they're taking once a day. So it's telling you in the brand name your dose, like how they're taking it, okay? So that's just for you to know what that means. Okay, told you that drug companies are smart. They like to make money, all right? So these are different decongestants that we have that are supposed to be geared towards those disease states that we would typically try to avoid with our previous decongestants that we talked about. So you have your cortisone HBP, which is the brand name, and what they're trying to say is, hey, if somebody has high blood pressure, HBP, high blood pressure, then I can give them this and they shouldn't expect to see anything change with their blood pressure. So they're using one of our first gens, which didn't cause a lot of sedation, to try to help with the decongested portion of it. Hit or miss. Some people say that it works great for them. Some people say that it doesn't do anything at all, okay? Because you have the HBP cough and cold, when we talk about suppressing coughs, we have the dextromethorphan that's in here. And some people, they kind of get addicted to the way that it makes them feel. And so you do have the abuse potential when you have your cough and cold formulation of it. And then you see that when we're looking at our nasal strips, something that's not medicated, right, is just anatomically trying to lift up, open up those nasal passages. So it's like a breathe right, like those little strips that people buy. We don't have these in the pharmacy, but they are good for your patients who might have any of those comorbidities that we talked about, pregnant, elderly patients. These are all different ways that you can try to help them with breathing. Also, a big thing that we tell people too is try to prop up their pillows so that they're not lying down. And be very careful in our pregnant patients. I think it was on one of the slides, but you can use pseudoephedrine in a pregnant patient. Avoid it in the first trimester though. You need to make sure that they don't have high blood pressure, okay? Because like remember, whenever someone's pregnant, they can develop high blood pressure because of their pregnancy. But make sure that you're understanding that sometimes if you don't feel comfortable when it comes to pregnancy, talk to the OB, right? And have that patient talk to their OB/GYN. But you can use some of those, but we do try to avoid that pseudoephedrine specifically within the first trimester of pregnancy for those women. And then our intranasal saline, remember I told you you can use it. It's pretty safe. The only thing that becomes a problem with the intranasal saline is some people will do the flush and they'll put it like in their nose. And if they're sick, then bugs just kind of populate and multiply on top of there, and they keep putting the same thing back into their nose. And then sometimes with some of those bottles, people don't let the bottle dry out or like leave the top off, and then the bottle grows mold in it, and then they will put their new solution in there, and then they're flushing their nose with dirty water, essentially, right, with moldy water. So make sure that you just give those counseling points depending on how they are receiving the intranasal saline, because there's several different ways that they can receive that intranasal saline. All right, so our intranasal options that we have. This is looking at what we were just talking about, essentially understanding that this is just cleaning out those passageways. If there's congestion, sometimes this will help. A lot of the times with your newborns, like your kiddos, whenever they get sick, this is one of the only things that we'll initially tell them to use to try to help flush out that congestion and the mucus that that child is having. There are some people who use this every single day. They're outside, they're breathing in all kinds of things, and so every night they will use a saline flush to kind of clean their nasal passages so that they don't get sick. It works, kind of, but there are so many different ways that you can get sick throughout the day, right? Homemade remedy. I would be cautious with telling patients how to make this at home. Yes, they can do it, but you got to make sure then everything is clean, because now you're gonna take that solution that you made, you're gonna put it in your nose, right? So you need to make sure that it is sterilized, that it is clean, that they're not holding on to it for a very long period of time, and it's growing things, okay? So just order it, we have it. We have lots of it in the pharmacy. This one is more of like a spray or a mist to where it's in the bottle, they squeeze it, and it comes up in kind of like a fine mist in their nose. This is like the neti, like a cheaper version of a neti pot. And I tell people to use this in the shower the first time, especially if they're not familiar with how it works, because it makes a big mess. So when they get, again, sterile water, and then it comes with these little packets right here. So these packets are what have the medication in it, right? Our sodium is in this. And so they're gonna fill it up. There's a line that's about right here. They fill it up, they put the water, distilled or any type of sterile water that they're gonna use, and then they pour the packet in, they shake it, make sure it's all dissolved. And I tell them to get in the shower, because when you try to tell people to do it over the sink, it gets everywhere, it gets on their clothes, and they will say, I don't wanna use it anymore. If they're in the shower, they're already wet, or they're in the tub, they're already wet, and they don't really care. They squeeze it, and then it's supposed to come out on the other side. Like it'll flush out on the other side, and then they switch, and then they do the other side to flush it back the other way. Okay, so it's supposed to help clean out everything, mucus, whatever is there that could be potentially causing the congestion. And then this is kind of what we were talking about before. If they don't use sterile water, if they don't let that bottle dry out, you can see where now they're causing an infection to themselves because they use dirty water, contaminated water, or their bottle is now contaminated. Intranasal steroids. This was our thing that we said was the best thing that we had, the most effective thing that we had, because it's going to help with all of the symptoms that my patient could be potentially presenting with. Anti-inflammatory, that's going to help decrease all of the mediators that come to that area. Doesn't matter if it's a late or early exposure to whatever that allergen is. The reason why some of our other meds they're not as effective is because they might be present in that early phase of the allergic response, but in that late phase, there's nothing there, so then that person continues to have breakthrough and they need to take it multiple times. This, because of that duration that it has of the medication, kind of attacks all of the phases that that patient could be potentially presenting with. Does take a little while for it to work, so a couple of days for it to work, and then you'll see that maximum effect. Hopefully your person doesn't have to use this for a very long period of time, but the maximum effect in about 2 weeks. This is why you'll see this more with our patients on that moderate to severe side, right? They really need to have something on board for them, so that's why we use our more effective medication there. When you see someone who has congestion and you're using a nasal spray, one of the big counseling points that you need to make sure that you tell your patient is to blow their nose prior to them putting in the nasal spray. A lot of people will use the nasal spray and then they will blow their nose right after. What did they just do with their med? They blew it out, right? So make sure that they're cleaning their nose afterwards and then not creating the desire to want to sneeze or blow their nose by not that strong inhalation, but just a regular inhalation. When you breathe in deep like that, most of the time you're going to sneeze or you're going to want to blow your nose because it's just a natural response because you just inhaled deeply that medication. So again, making sure that they, however they need to, blow their nose, do a saline rinse, what have you, it doesn't matter. They can always clear out their passages, and then wait at least 10 minutes before they blow their nose afterwards. We were trying to let that topical medication get absorbed. Okay, so we want to leave it in their nose as long as possible. And then this is talking about the potential of having an oral steroid being put on board. Hopefully something does not progress to this, but it can be very bad for some patients. So when me and my husband first started dating, he's allergic to dogs. I was actually allergic to dogs, and I didn't know that because I had a dog for like 15 years by the time they said I was allergic to them. But he was allergic to dogs. He didn't know. And so he would come over, and like his face got super, super swollen. His eyes were swollen. He couldn't put his contacts in anymore. And I was like, oh, this dude something's wrong with him. Like, I was like, oh, you're sick, just stay away. And he was like, this has never happened to me before. Kept going to the doctor, they're giving him eye drops, they're giving him everything, and finally they allergy tested him. and found out that it was my dogs. And they were hypoallergenic dogs. But he had a very, very bad response to the dogs, right? So whenever the intranasal wasn't working, his eyes were messed up, his nose was congested, they ended up having to give him oral. So he had a burst of oral steroids to help everything calm back down so that he could then, not have the super swollen eyes. His nose kind of got uncongested, and then decongested, and then we just did meds, allergy meds every single day. Okay, so again, it can be something that gets very bad to where you're doing a burst, which is why we call it a short course. We don't keep them on these for a long period of time. You'll also see bursts of steroids used in our patients who have asthma also. We'll do a burst of steroids if they have like an acute exacerbation that we can't control with our inhalers, okay? So you'll see this kind of come up again. I just want you to remember that we typically will use prednisone that we're gonna treat them with. I don't need you to remember the dose for your adults versus your peds patient. Just know what the med is that we typically will use. Adverse effects. Again, the same things that we talked about before because of the fact that we're using this intranasal form. Okay, so I can have drying, stinging of that nasal passage. I can have where they're having their nosebleeds, growth suppression. This happens because somebody is using a very high dose or they're using it a lot, okay? That's the only way that this kind of becomes more systemic because remember, if my issue is in my nose and I'm giving it topically in my nose, I'm less likely to see a lot of this stuff occur, but this is because they're using it so often and because they might be using a higher dose, more likely a kid, right? Because that's the only person who's still growing. I'm not anymore, right? So this is where you'll see that in your kid. The aftertaste, again, that we talked about in that septum preparation, again, if they're doing this instead of doing this, that becomes a problem, so always just show them outward, point away. Interactions, for the most part, there's nothing that you need to be worried about. You see that we have some inhibition going on. If there is a CYP inhibitor in its presence, again, I don't make y'all remember exactly which one, as long as you know that there is a CYP that could potentially inhibit its content or cause inhibition, which would then increase its concentration. That's all you need to know. Here are all of our different steroids that we have. So, fluticasone, this is just different formulations of it. The mechanism by which it is topically applied is a little bit different, so the apparatus is a little different, so that's why you see those different salts. But if you know fluticasone, you know that it's a steroid. Mometasone, budesonide, all of these that are above are considered your first generation, so you can write first generation on that. When you look at these, they don't have as much or not as high of a bioavailability. So that's why we can see that we don't have as many side effects, and we like to use these in our pregnant patients. You see all of these say likely acceptable, and they all say that there's limit systemic absorption, which then means that it has a lower bioavailability. Versus comparing it to your second gen that you have, which is your triamcinolone, beclomethasone, and your flunisolide. These are all your second gens. These all have high bioavailability, and we don't like to use these in our pregnant patients. We don't like to use these in our pediatric patients either, because remember we talked about the growth suppression that might happen if they did have a lot of exposure to the steroid. So these we don't like to see used in our younger kids if we don't have to. These are a lot better for us to pick. Also with your budesonide, remember if the baby is coming, budesonide is better, okay? So you have budesonide as the one that we prefer, not saying that these are not safe, we just know that this has a better pregnancy category. This is the one that we typically will see used more, okay? All right, this is a combo. So this is the one that we saw that was in purple, I believe, and it said the inhaled antihistamine with the inhaled corticosteroid, and you saw it like it had inhaled and then both of them in parentheses. This is what that is. This is your Dymista. So it has the azestylin in combination with your fluticasone. So your azestylin is the antihistamine portion, your fluticasone is your steroid portion, and all we did was put it in one medication for them. Ta-da! These are two different things that you could also have prescribed that patient separately, right, that they could have been taking, okay? So looking at this is very good for our patients who have seasonal allergies as long as they're over the age of 6. And then you see that, again, I just have this more convenient for my patient to take one med instead of having to use 2 different nasal sprays. Good for several different symptoms that they could be having. So congestion, runny nose, itching, sneezing, which were our hallmark things that we were seeing with allergies. This is why we can use this. This is more effective than you using either of these drugs alone, okay? So that combo of using them together is better than them just using an antihistamine or just using a steroid. The combo says, cool, I can attack this in 2 different ways, right? Adverse effects, you can see some drowsiness that occurs. Again, if they are not doing the application correctly, we can see where they have all of those different things that we already talked about, right? So the preparation, the nosebleeds, any of those things could happen. Higher the dose, the more likely you are to see these last 2 things. So if they're using it very frequently. Impaired wound healing and your Candida albicans infection, which portion do you think that's coming from? The antihistamine or the steroid? The steroid portion of it, right? So I still have a risk of having this occur in my patients because I have this steroid portion on board, which is a common side effect that we always see. And then the changes in taste, we talked about the bitter taste. Some people will say a metallic taste. It just depends. So just understand, again, if I'm putting something up my nose, that's something that could always happen as an adverse effect. Interaction is typically safe. We don't have a lot of issues. All right, your anticholinergics. Again, last semester type of revisit, but specifically looking at using it in this situation. So again, muscarinic antagonist, and what we're trying to do is say, hey, I want to dry things up because that's what my anticholinergics do. They dry things up. So what are my adverse effects, especially if I use too much of it? Well, now I have nasal dryness, which what can I use to help with that dryness? The saline, right? I have my saline mist that I could give them. Dry mouth, and then that nosebleed again. Also, side note onto the saline, you'll also see now where some drugstores will carry, we don't have it in our pharmacy yet, but we have a nasal, it's a gel. So it's saline, but it's in a gel mist, so it stays around a little bit longer than like the sprays that we typically have. So within our DOD facilities, MTFs, all that, we have the mist. We don't have the gel, but they can go out and buy the gel, which stays on longer. So our medication that we have is going to be your ipratropium or your Atrovent. You see that we can use it in several different kids, but make sure that you're looking at the fact that this is the drug that goes with an anticholinergic, what the mechanism of action is, and understand that you're trying to say, I want to use this, like we said, for everything else for a short period of time. So that's just to sum this up. You don't need to know every single thing in detail. Not something that you'll also typically see used in pregnancy, right? So anticholinergic, what my mechanism of action is, same side effects that I've always seen, right? Except now I'm seeing more of the anticholinergic effects of drying things up and then looking at my medication that falls under this class. Mast cell stabilizers. So when we look at this, we have one, cromolyn. Cromolyn is a good drug if you know when something is going on. So this is, again, mast cell stabilizer in the name. It's stabilizing that mast cell so that it doesn't undergo degranulation, which will then put out all of those mediators, which causes that allergic response. So if I can stabilize it and prevent that from happening, then I don't have that allergic response and I'm helping my patient not have that allergic reaction, right? So this is more so something that we use prophylactically because we know that this patient is going to be experiencing an allergy to whatever that thing is, the season, the pet, the going to visit their parents' house, whatever. The thing with this is it's very, very, it's safe, but it's not as effective as other things because, again, it takes a while for it to have its onset. So about 1 to 2 weeks before you even know what that exposure is. So if I don't know my exposure, this is useless for me, right? So this is, again, one of our seasonal type patients that you could use this in. Headaches, aftertaste, stinging, these are all the things that we saw already, right? That was happening with any of our nasal because it's a nasal administration. And then our drug that we have, make sure you're understanding the age, 2 years or older. We do have this in a pharmacy, but they can also go and get it over the counter. Here's a check on learning. 34-year-old female wants assistance with her allergies. She's having lots of symptoms and she's sneezing a lot throughout her day. And so she's moderate to severe, persistent. What do you think would be the best thing for us to give her out of these things that are listed here? D, right? So if I gave her, because she's severe, moderate to severe, and she's persistent, I want to put something up her nose already. I know that, right? Not like that, y'all. Not bad things, okay? We're trying to help her. So these oral things kind of get knocked out. This is going to help her, but it's not the best thing that I have to help her manage her symptoms consistently, right? So she could do this before she did this, but this is the thing that's going to actually help treat her condition that she's having, okay? All right, allergic conjunctivitis. So when we're looking at this, we have our typical symptoms that our patient may present with. You see the itching, you see redness that could be happening. Sometimes people will have like swelling. They may or may not have. Most of the time, watery discharge, you can see sometimes where it might have a little tinge to it, like when they initially wake up. But most of the time, you're going to see that watery discharge that's happening. Our goals, help them. The same thing that we talked about before, right? Just make them more comfortable. So when you look at this chart, a little bit easier for us to see, you have your primary care and your specialty care. What aren't you going to be touching? Steroids. You're going to refer them if you get to that point to where they need a steroid. These are all things that you can end up dealing with. So you have your artificial tears. That's just going to help them if they are experiencing a lot of dryness, things like that. Also to help them flush out the allergen that could have been in their eye that they were exposed to. So this is kind of equivalent to your saline rinse that we said for our rhinitis. You have your cold compresses that you can use. This will help if somebody is very swollen. This helps, but it also relieves the amount of itchy, like grainy feeling that some of your patients will say that they feel. So it seems very like, oh, a cold compress, but it does help. Make sure that they're not using the same, like if they take the washcloth or whatever they're using to like cover themselves with, that they're not taking it, putting it down on something dirty, and then they come back later and then they pick it up and they're putting it back on their eye, because now they're just putting germs back into their eye, okay? Decongestants, we already said that we use these before for congestion of the nose. This is going to help with the redness. Antihistamines, mast cell stabilizer. Which one was the mast cell stabilizer that we just talked about? Cromolyn. This is the same thing that we're going to use here. NSAIDs, we talked about these. These are going to help sometimes, depending on how your patient is presenting, but we have drops that they can use in their eye to help them not itch as much. And then some of these we have in combo, so that's what you're seeing there. And then depending on what's going on, you see that you have your corticosteroids that may be used. A lot of the times, depending on the way that your patient is going to come in, you can see that you can have the options that we talked about previously for our rhinitis be used, and they could potentially help with the allergic conjunctivitis that's happening in our patients also. Most of the time we use them together. Same things that we talked about before, avoid the allergen. If they have mild symptoms, we can try an oral antihistamine, or we can do drops if someone doesn't want to take something all the time, or if they have a heart issue, or if it's like with administering the eye drops. You also have those artificial tears and the cold compress. When we hit to our moderate, now I'm worried about, or if I hear somebody at any stage tell me about redness, then that's whenever I can use my decongestant. You can see that I can use an antihistamine with the decongestant, which is kind of how we were talking about our Allegra-D, things like that. This is the same kind of thing, but now instead of it being a tablet, it's going to be a drop. Your mast cell stabilizer, which is the same drug, different formulation. So you have your cromolyn, your antihistamine in combo with your mast cell stabilizer, and then your NSAID that you can use specifically for itching. So make sure you're paying attention to when you're using each of these medications, right? What did your patient present to? What am I telling you their symptoms are? And then you're picking the med to target that symptom that they're having. This is your severe, where you're like, hey, optometry, I have somebody coming your way. They're gonna probably need some steroids because nothing else that I did helped them. So if you look at it this way, or you look at it this way, same things, just telling you how to stepwise treat that patient as they're getting worse. Looking at your antihistamines, you see that these are non-selective H1 receptor antagonists. So same thing that we talked about before with our antihistamines, these are just now going to be our ocular formulation. So same exact issue that we had before with our side effects. You learn one, you kind of learn the other. Difference here is that now you can see that you have those visual disturbances that are occurring because I am putting it in my eye, right? So I'm more likely to see those. So again, these are the same things that you already saw. Your drugs, azestolin and your levocabastine. When you look at this, we'll look at the next slide, which is one of our more selective options, and you'll see that we do have some that are more selective, which means that it is more superior. We also order it a lot more, so that's what it's talking about, this Patanol, which we'll get to. And then because this is a suspension, the levocabastine, you need to shake it. So anytime you see suspension, even if it's an oral medication and you see suspension, that means that the drug is suspended into some type of solution. So before you administer it, you have to shake it to make sure that the medication gets dispersed again evenly, and then they would put in the drop, okay? So this don't see so much because there's an extra step that patients are not likely to do or to remember, whereas your azestolin, you're gonna see this a little bit more. All right, when you're looking at, again, your selective, so now this is just saying same thing, same target, H1 antagonist, but this one is the more likely one that we have, which was on that other slide where it's saying more superior to my azestolin, I have my olopatadine or my Patanol. When you look at this, just know that this is the best one that we have. You also see that we have ketotofen as an option. Good medication, if they can't get to you in time, they can also go and get it over the counter. They don't need to have that prescription for it. So that's the benefit of this one over your olopatadine, but your olopatadine is the best one. Okay. All right. Again, ocular decongestants, mechanism of action, same thing that we talked about before, but now it's working in the eye to decrease some of that redness, potentially swelling that the patient may have. They can get that rebound hyperemia if they use it over the 3 to 5 days. So that same thing, because it is a topical administration of this medication, we need to make sure that we're avoiding that. Conjunctivitis medicamentosa, again, that's just decreasing how long you're using it for. They shouldn't be using it over the 3 to 5 days anyway, so you shouldn't really be seeing this side effect. Because if you see that, you're going to see your rebound hyperemia anyway. And then again, the visual disturbances and that increased ocular pressure just by way of my mechanism of action, right, my mydriasis. Looking at the medications that I have available, you have your tetrahylazoline, which is your Visine that you see people using all the time. And then you have the antihistamine and the decongestant combo. So instead of somebody using 2 drops and waiting a certain time period in between before they can administer the next one, this one has it all together in one formulation. So they have the decongestant and the antihistamine in here all together. You see they're both over the counter. They don't need you for either of these, okay? Don't need you to remember doses. All right, mast cell stabilizer, same mechanism that we've already talked about. We already said that this takes a longer time for it to work. So if I am coming to you because I have something going on with my eyes, and you're telling me like, oh, you're gonna need to wait a couple of weeks for it to work, that might not work for me, okay? So this is, again, something that we're using prophylactically. We know that they're gonna come into contact with something. We can prescribe this a couple of weeks before they come into contact with whatever that allergen is. This is not something that's very fast. You will see sometimes where we may give them an antihistamine to help with their symptoms that they might be having immediately in conjunction with this, and then we'll take the antihistamine off and we'll leave them on this if we see that there is a pattern. But again, it's there. Now you see we have more options that are going to fall into these stabilizers. So the cromolyn is the one that we discussed. This is the one that I see prescribed more often. The lodoxamide and then the netochromil. are two other options that you have. Again, don't remember dosing, that's for you later. All right, ocular NSAIDs. So same thing that we talk about with an NSAID and decreasing the prostaglandins, which were a part of that cascade that we had with the inflammation. That's going to be that net result. This will help stop the inflammation. It can also help stop some of that itching that that patient may be experiencing in their eye. Side effects, same thing that we talked about before, because of the fact that they are administering it in the eye. And because it is an NSAID, remember, if somebody has an allergy to aspirin, because aspirin is an NSAID, right? So if somebody has that aspirin sensitivity, which some people do have, what you will see is that they're going to have they could potentially have an asthma attack as a result of the drops, especially if they're using them 4 times a day, right? That's frequent dosing, okay? And most of the time, people don't follow directions and they don't just put in 1 drop. They usually just, okay, like, so then you're more likely to see these things happen. Ocular steroids. So this is where we were talking about if you have to end up at this point, you're going to end up likely referring your patient, but we know that steroids are anti-inflammatory medications that we're trying to use to decrease inflammation. Now the difference is that this is in the eye, so more severe case, you tried all of your steps and it didn't work, hey, let me go put in this referral for the ophthalmologist. Adverse effects that can happen, infections, all the same things that we always talk about with steroids can happen if somebody is using this. This is why they're closely followed by the ophthalmologist versus you doing something like this. Increased IOP, cataracts, several things that can happen. The med that we have on board, bless you, is your loteprednol. Again, just make sure that you understand what med falls under there, who is the person that you're referring them to if you did need to use this, and then your adverse effects that we saw on the previous slide. When we're talking about our administration of our eye drops, very important for you to make sure that you're counseling your patient on how they're going to administer an eye drop. Because if they get the tip of that dispenser dirty, if they don't know how to properly administer it, what can then happen is that they're going to cause a different problem, which will be an infection, okay? So make sure they're washing their hands and you tilt their head back. Some people will either lower the eyelid. You'll hear also some providers tell them to like make a pouch so they squeeze under their eye and it makes like a little cup. And that's where they're trying to get the eye drop to go into. So they squeeze that eye drop and then they close their eyes for a little while. Now what I thought was very interesting was that I never remembered to place my hand on the duct. So if they place their hand, I think it's right here, on the tear duct, it minimizes how much goes systemically. I always am like, I need you to get in there. So I never used to do that, but I was like, that's not the right thing to do because if I get more systemic absorption, what do I have more of? Side effects, right? So just that, and then if they have 2 different drops or if they're doing more than 1 drop at a time, what you should be doing is waiting this time frame in between, so at least 5 minutes. So that's why when we have those combo of the drops, it's better for the patient and it's easier for them to adhere. You're waiting in between because you want to give the body time and the eye time to absorb the medication. If you just keep putting in drops and not waiting in between, it's just going to run off and they're going to be wiping it off anyway, okay? So that's what you're waiting for. So 5 minutes, putting their finger on the tear duct. If people touch their eyelid with the dropper, I tell them to get either baby shampoo to like wipe it off, but make sure that they're not like running it underwater because the water can go inside of those little holes that are at the top. If they seem like they're with it, because some people you'll be like, I don't know if I can even trust you to put an eye drop. I sometimes will tell them to wipe it, not press down hard with alcohol around it to just clean it to make sure that, but some people, okay. So most of the time I'll just tell them to just wipe it off. Your memory jogs are here. Again, remember, those are for your review. Kind of has quick summaries on there. And then I will be back at 1 o'clock, or if you tell me early.